Okay, thanks, Paul. First of all, I'm going to say I'm very much here on behalf of the team in Musina, who I think are watching online, so I hope I'm going to do them justice. So first of all, I'm going to talk about provision of antiretroviral therapy to migrant farm workers. So why are we saying this population is vulnerable? So this is just a picture of how you or I might cross the border between Musina in South Africa and Beitbridge in Zimbabwe, compared to the picture on the right, which is how many of our patients are actually crossing the border. So they come across the Limpopo River, which is dry and sometimes full. They're often robbed along the way, maybe sexual violence is involved. And many of our patients are doing this every couple of months. So basically, what I'm going to talk about now and describe is how the team in Musina adapted a model of care to try and start people who are doing this on antiretroviral therapy and keep them on treatment, and to describe the kind of initial outcomes of that programme. So just a bit of background. Worldwide, there's 125 million people living and working outside their country of citizenship. And in the southern African region, there's a huge amount of mobility going on. A lot of internal migration, particularly between rural and urban areas, but also a lot of out-migration. And if we look at Zimbabwe, particularly obviously during the periods of political and economic instability, there's a huge kind of efflux from the country, particularly into South Africa. Are migrants more vulnerable to HIV? Well, I think the answer to that is yes, and probably in two ways. So they're more likely to get infected, and there's quite a lot of documentation around that. But also because they're more vulnerable because it's difficult for them to access care. And that's because often they're afraid to present themselves to health services. Often they don't have the documents, and so they're afraid of what they might be asked at a healthcare service. But also the attitudes of the healthcare workers. They might not want to treat people if they're language barriers from other countries, but also because we might think, oh, they're not going to adhere, so why even bother starting them on treatment? So what's happening in Musina? So Musina is in Limpopo province, population of around about 57,000, and almost half of that population is working on farms which are scattered all along the border there with Zimbabwe. MSF started working in Musina around about 2008, and selected 6 farms, and initially provided mobile primary health care. So basically, they go out in their buses once a week to each of those farms, set up tents, and provide primary health care. When they were doing that, they also provided HIV testing, and what they found is that almost a quarter of the farm workers were HIV positive, compared to 14% in Musina district itself. And because they had to refer to the hospital in Musina, which in some cases was about 50 kilometres away, only about half of those who were eligible for ART got on to treatment. Never mind whether they stayed on treatment, but were initiated. So what the team decided to do, kind of seeing those figures, is to integrate HIV/TB into that mobile clinic. So they started to train the nurses and the counsellors in the provision of HIV and TB care, and basically integrated that into the package of services that the mobile teams were providing on a weekly basis to each of those farms. And in addition, they kind of sat down and said, what do we have to do different in our adherence package to help keep this highly mobile population on treatment? So the first thing was, every single time we see a patient, we ask them about their travel plan, and that is documented in our file and also on the patient's own patient-held treatment card. We developed this health passport, which is basically a very simple piece of paper which outlines the patient's treatment details, their latest lab results, and it also what we do for every patient is identify an ART site from the village or the nearest to their village in Zimbabwe, and write all the details of that treatment site on this card with a telephone number, so that they are very clear about where they should access care when they go back to Zimbabwe. We also kind of had to adapt the content of our counselling. And one of the real challenges is that despite on paper the national protocols in the Southern African region in theory having the same regimen, that is not really what's happening on the ground. And so going between South Africa and Zimbabwe, in South Africa we used tenofovir and efavirenz, in Zimbabwe it's tenofovir and nevirapine. And in South Africa, we still don't, at the minute, use fixed-dose combinations. So the regimen would be 3 pills in South Africa versus 1 pill in Zimbabwe. So for the patients, the tablets look different, the bottles look different, and it can be quite confusing. So our counsellors spend quite a lot of time going into the details of what changes they might expect if they had to access care the other side of the border. We then took the liberty of adapting the monitoring and evaluation. I don't want to kind of bore you with all the ins and outs of HIV kind of monitoring and evaluation, but basically we kind of came up with a new category called a temporary transfer out. And basically that's anybody who told us, I'm going to travel for 2 weeks or more, but I'm going to come back, okay? But if that person didn't come back, we would categorise them as a transfer out rather than a loss to follow-up. And for anybody who was a temporary transfer out or a transfer out, they got a longer drug supply, so 3 months of drug supply, and also this tail protection. So that's very simply a 1-week supply of drugs to prevent resistance if that person was forced to stop for whatever reason. So their drugs were stolen crossing the border, or there were delays accessing an ART site in Zimbabwe. So the methods, this was a very simple observational cohort study. We did a folder and register review of patients initiated between November 2010 and October last year. And the data was entered into electronic register and analysed in its data. So the first thing we looked at was what was the impact of just providing mobile HIV/TB care on access to ART. This is a bit of a busy slide, I'm sorry, but in the minute we're all obsessed with cascades in the HIV world. So I just want to look at the green arrow. And basically what we saw is by going mobile, there was a 37% increase in the number of patients who actually came back and got their CD4 result. And there was a 32% increase in the number of patients who were eligible who were initiated on ART. The cohort data, so this is just a baseline characteristic. So we had 269 patients initiated, median age of 36, 58% women, and then baseline CD4 count of 181. So outcomes at 12 months, so our target outcome, kind of standard WHO, is 85% at 12 months, and they achieved 86% retention in care at 12 months. And just for a bit of comparison, I looked at the MSF cohorts from South Africa and Zimbabwe, very similar, so very similar outcomes from this very mobile population. In South Africa, we have the luxury of routine viral load monitoring. And again, both at 6 months and 12 months, 90% and 92% suppression, which again is very comparable to what we see in the cohort in Khayelitsha in Cape Town. What about these temporary transfers out? So we looked at our documented temporary transfers out, and what we saw that 71% of them came back, with 3% of those coming back late, but they had access care ART in Zimbabwe and had stayed on the same regimen. 10% of those temporary transfers out came back late, but they had stopped using the tail protection they were given, and hence, we hope, prevented the development of resistance. And 17% did not return, and because they were given the full transfer letter, details of the ART site that they should be referred to, they were documented as a transfer out. So, coming back to my patient crawling under the wire there, I mean, I think the real lesson from this project has got people talking about, it is possible to provide antiretroviral care to people who are going back and forth across borders like this highly mobile population. And at regional level, it's kind of raised these issues that we need to be lobbying for, which is we need the same regimen. And I say on paper we have it, but in practice it's not practically there quite yet. We want the same kind of paperwork in the region, this idea of a patient passport. Every country has its own TB card, ART card, which can be confusing to nurses who see a different paperwork and don't quite understand all the intricacies of it. And also kind of coming back to learning lessons within MSF programs. I was at a course in Cape Town a few weeks ago and kind of asked several of our kind of program managers how many migrants do we have in our programs, and really met with quite blank faces. And so I think it's a question we need to be asking ourselves in our projects is, how big a problem is this, and how should we learn some lessons from Musina in terms of adapting our model of care to this vulnerable population? So I'd like to again thank the Musina team and the people living with HIV in Musina.